Bethany, is anything going on?
I think it is. I was just having to wait for just a moment.
Okay.
Okay. I do believe it is recording, so it usually has a little recording that comes up. Okay, I'd like to welcome our speakers today. Again, we have just a great panel here. We have Christina Campos with Guadalupe County Hospital in Santa Rosa, New Mexico. Christina is the Chief Executive Officer. We also have Mary Keogh. She's the Principal Consultant with Stroudwater Associates. And Carla Wilbur. She is a Senior Consultant with Stroudwater. I'm just going to briefly highlight their backgrounds, but I encourage you to review the bios on all of our speakers. It's at the end of the agenda. Christina is the Chief Executive Officer of Guadalupe County Hospital in Santa Rosa, New Mexico. She's worked in healthcare since 1993, first as a hospital volunteer and a community encourager under the Community Health Development Program, and then later became a financial officer for the small Frontier Hospital. She currently serves as the chairman of the New Mexico Rural Health Network. She is also a New Mexico delegate to the American Hospital Association Region B Policy Review Board. She's a busy gal. In 2013, she was even appointed to Department of Health and Human Services Secretary Kathleen Stalupis to serve on the National Advisory Committee for Rural Health and Human Services. Thank you so much, Christina, for joining us. It's a pleasure. Mary is a Principal Consultant at Stroudwater Associates. She has 40 years of experience in healthcare, and most everyone across the country knows Mary. She assists rural hospitals and clinics across the country with various quality improvement processes, quality scores, ED, emergency department operations, you name it. Mary has been there and done that. Mary holds a Bachelor's of Science in nursing, and she is a registered nurse, and also a concentration in adult education and business. Carla Wilbur, she is new to Stroudwater as of this past year, and we're thrilled to death that Carla can join us. And she's going to be just a great asset to our program and to the rural hospitals across the country. So Carla, thank you. Carla is a senior consultant with Stroudwater Associates. She's an accomplished nurse administrator. She has an extensive background in critical care and education, emergency services. She's also a registered nurse and holds a doctorate in nursing practice and a master's in nursing leadership. So welcome, all of you. We also have Terry Hill, who is going to facilitate today's call. And Terry Hill has an extensive background in rural health for 40 years. He is really the visionary for the Rural Hospital Performance Improvement Project, which is the model program for this program, the Small Rural Hospital Transition Project. And just his vision has just been so helpful to so many across the country. It's a pleasure. Terry, I think I'll turn it over to you now.
Thank you so much, Bethany, and good morning, everyone. We have a topic today that I'm particularly excited about, and it's particularly important now, not only for all the old reasons and all the right reasons, which was all about better patient care, better quality, et cetera, and that should be motivation enough, and it is for me, and I bet for the folks on this call. But now we're seeing a transition in payment systems where quality is becoming very directly associated with financial improvements as well. And kind of in that regard, a heavy emphasis within our program has been helping rural hospitals to prepare for the future payment systems, which are going to be based upon value, and value basically is quality and patient satisfaction, and then moving into population health in general over cost in that regard. So within our program, our transition program, and we are funded by the Federal Office of Rural Health Policy, we have placed an emphasis this year about models, creating tools and resources that will help rural hospitals across the country make this transition. Kind of in that regard, we hold frequent webinars, and I hope you folks that are on the call take advantage of those, because they're really very valuable. They're great. Really want to again direct you to the resources we have on our website, ruralcenter.org. What we do besides this, and this is supplemental, is to create conversations, which I personally believe can be very valuable. So it's more than just preventing education. It's more than just providing tools. We think there's a certain power in conversations as well, particularly when you have folks like the folks we have on this call who have expertise, leadership, et cetera, in this area that is becoming so vital. So today we're going to talk about a particular project that we and the federal office have funded, and then look larger at the concepts that kind of are driving the quality improvement model, community care coordination, et cetera. And then we want to invite you folks, if you have questions, to ask them, put them into either the chat box or just let us know by hitting *2 and asking your question as well. So with that, I'm going to move into the questioning. And the first thing we're going to do is ask Christina, who is our hospital administrator, why the Guadalupe County Hospital decided to really get into a project dealing with care management and transition in care. A lot of our other projects deal with financial improvement, and so I would wonder why did you choose this project, Christina, and what did you hope to gain by participating in it?
Well, when we looked at the grant originally and what was being offered to us in terms of financial review and quality, we had just entered into an agreement with a consultant to come and do a charge master review. We've had really, really clean audits in the last 10 years. We have very healthy financials, balance sheets, days of cash on hand. So we felt we had kind of a handle on it. It was hardwired with all our policies and our procedures in accounting and financials. But we didn't have that good of a handle on quality. We had really good quality scores. We had really good HCAP scores. But I had a sense that until we actually put it in writing, it felt almost like good luck or goodwill rather than something that you could sink your teeth into. And then if people left the organization, if we had turnover, it would continue to exist as long as it was in writing and written out. And then we also knew that as well as we were doing, everybody's improving. So it wasn't good enough to do well. We had to do better because everybody's catching up. So if we didn't continue to improve, and honestly, we could not really move forward until we had somebody come in with the expertise and the objectivity to tell us what we were doing well, but also where we had opportunities for greater improvement and that opportunity to move the needle forward.
And Christina, you mentioned hardwiring. Could you talk a little bit more about that concept? Because what I'm hearing from you is that it would kind of put some permanence or certainly building it into the culture itself. Talk a little bit more about what you mean by hardwiring.
I think putting it in writing was very important, establishing policies and procedures, having our board of directors sanction it, support it, champion it, not just it is a philosophy, and it is important because, I have said in the past that, quality is not just the policies and the procedures and the departments and the staff. It is a philosophy. But if it's only a philosophy and it's not adopted as a policy, if you don't have the forms, if you don't have the mechanisms, if you don't have that buy-in in writing from everybody, if you don't have meetings and agendas and minutes and all that, it's easy for it to disappear. And we have had a lot of turnover in the past. We haven't recently. We've had some key turnover, but not substantial. So it was really important that when we possibly had turnover in the future, we didn't want our quality program to dissolve. We wanted it to be set for the future, permanent, and something that we could review at and say, how do we do things? One example that I can share is we have a very, very good personnel policies and procedures. We have a very in-depth personnel policy manual. We review it every time there's a question. If an employee comes in and says, how do we do this? Let's pull out the manual and look at it. And I really wanted the same thing for our quality. I wanted to elevate quality to something less fluffy. We've always believed in it. We really push it. Our patients score us well for it. But it had to go beyond that. And it had to be, and I think that's why we call it hardwired. It had to be something that you could see, that you could touch, that you could pass on to other people.
And let me also suggest that the other key position here that we need to be mindful of is the CEO position itself. And that in essence, with Christina's excellent leadership, her hospital has achieved really great things. They're obviously a model. If Christina leaves and the concepts and the processes are not hardwiring, we basically bring in some organizational uncertainty and instability, et cetera. And particularly because there is relatively frequent turnover of our rural hospital leadership, it really speaks to the need to kind of hardwiring from what I'm hearing you say. So it's not just the director of nursing or the other key leadership positions here. It truly relates to the CEO's position as well.
Yeah, and I believe that's why if you push it all the way to the Board of Trustees, where it's their position, it doesn't just stop at the CEO. And you ensure that when future CEOs come in, it's something that's been bought into by the entire organization already. And that idea of turnover is really, really real. New Mexico, the average tenure is about 3 years for a CEO. And I think I'm young. Others would probably disagree. But I've been in my position for 11 years, and within the New Mexico Hospital Association, I think I'm number 3 in tenure statewide.
Wow.
Just for having been at one hospital for 11 years. That's scary for hospitals because it's that dedication to quality, whether it be clinical quality, whether it be courtesy, whether it be quality scores in terms of clinical scores, if that's only attached to a CEO and your CEO is leaving every 3 years, you're never going to move ahead.
Yeah, very well said. Let me turn to our consulting team here, and Mary and Carla. Transitions of care have become huge, partially because they're so related to the new value formulas, partially due to the fact that hospitals are being penalized for these readmissions within 30 days. Mary, would you talk a little bit about why the hardwiring becomes a big part of why the transition, what's the relationship to transitions of care?
Yes, thank you, Terry. I do want to say first so that Christina is not patting herself enough on the back, and I can understand why, but she has been running a very, very good hospital. The staff definitely knows where she wants to go, what are her beliefs. She has no problem in sharing with them everything that's going on, including the board, by the way, which we met. And so that definitely helps that full concept. So she said, if the CEO leaves, it's got to have something that's going to stay there. I'm also for, if the CEO does not lead the march, then it is that much more difficult for everybody to be on board and for creating something that's going to be sustainable. So, Christina, Carla and I appreciated meeting you and your team and all the good work that you're doing over there. As for the transition of care, it's always been the right thing to do. We all understand that. But it's not the way, the way that we were paid was kind of undoing that thought of let's have the best discharge planning in the country and let's make sure that it's very sustainable, because if we lose admissions, if people don't come back, then what do we do? So for the past, we knew it was the right thing to do, but discharge planning consisted of what happened between the four walls, the time that the patient was in the hospital, and crossing our fingers that whatever we send them to is going to be working. Now, as you said, the value-based purchasing in PPS hospitals, there is a lot of reason to have good quality and transition of care because of the readmission. But even more so now, it's getting ready for population health management. Unless we have, a transition of care is a component of the population health management. So there's all sorts of things that we can do with population health management, right? We can, look at the data of our community. We can look at their chronic illnesses. We can put in programs to prevent even an admission. We can make sure that there is very good follow through and a strong team approach from the physician or the clinic team and the patient and family, that everybody is working at this together. But so then there are people that are admitted, and so for those patients, the plain old discharge planning no longer is sufficient. So the transition of care really starts from the usual discharge planning that we did before, to identify what is their needs and to try to put something together that we could do at home that they're going to need, whether it's DME, but now it's very important for the transition that our patients, number one, gets very good education while they're at the hospital, well documented, that we use best practice for, teach back to make sure that the patient understands what we were teaching them, patient and family. To make sure that we schedule an appointment before, with their follow-up before they leave. And this 2-3 weeks is no longer appropriate, because if you are sick enough to be in a hospital, then you probably should be seen within 2 days to a week with your physician to do a follow-up of some kind. Sometimes that can be just a follow-up call, but very often it has to do with, we have to have an appointment and make sure that everything is still up to par. Also, the transition of care, it used to be that, we wanted to make sure in the hospitals that we knew all the medication that the patient was on and that we tried our very best to give them the right medication in the hospital. And that is to prevent any complications and all of that stuff. But now that medication reconciliation is getting to be so important, not just internally, but externally, when they pass on to the next level of care, whether it's home with their PCP or a nursing home or a home with home health or a consultant that they're going to go see, we are accountable, we should be accountable to make sure that to best of our ability, we're turning over concrete information that the next step will take from there, so that we're not going to have patients that are taking 2 of the same types of medication but nobody knows about it, that type of stuff. Finally, the follow-up. So in transition of care, it's very important. A while back, people started to call patients after discharge, and the purpose was to make sure that they were happy. That really was, that they were satisfied with their stay, and was there anything that we could do? But now transition of care has brought that up to such a higher level. Our follow-up call must include, did they understand, can they re-verbalize all the instructions we gave them, all the education that we've given them? Are they having, did they not go get their medication because they couldn't afford it? Are they having transportation issues to get to their physician? So that follow-up call is now getting to be much, much more comprehensive. And then a lot of people, to prevent that 30-day readmission, is that they even do, for the more complicated cases, they do the follow-up calls on, 1 week, 2 weeks, 3 weeks, up to 1 month, to make sure that the patient is in good hand and has a good, start going with there. And then, naturally, the transition of care, we have to have very good relationships with all of the support that we have in the community. So whether it's Area Agency on Aging, it's our PCPs, it's our home health, it's a nursing home, it's our therapy, department in the community, we need to be able to really have a good handle and not just flip them over to somebody else, but that we even, we don't depend on the patient alone to be talking to the next level, that we participate in talking to those people also. I'm going to stop here and ask Carla if she has anything to add, but I personally do believe that unless that we learn to implement a super transition of care program from the get-go in our hospital, it will be very difficult to say that we have a great population health management program. Carla, do you have anything to add? *2.
Let me jump in here.
Yeah.
As somebody, my mother just died this spring, so when you're put, I'm going to represent the patient or the family perspective here on this, Mary, about how incredibly important these transitions of care are. Because my mom would be hospitalized, or she was in an assisted living facility in a rural area, or would be in a very, very good rural hospital. Every time she was transferred, and this happened repeatedly, into big hospitals in the Twin Cities in Minnesota, there were these enormous breakdowns both ways, both when she went in and when she came back out, et cetera. And again, the discharge planning, I'm sure, was done effectively in both hospitals, but there was nobody looking out for her in these transitional phases as such. And particularly as we're moving, as you said, into these new type of models, this piece is really where I think rural hospitals can shine, and where they can really can contribute to, a much higher quality outcome as well. So it's for all of us in that regard, or those of us that choose to live in rural areas, that this has been something, from my experience at least, that has been historic for quite some time. And they're also not just rural to urban, but very often between the hospital setting and the long-term care setting, where so many times these folks don't talk to each other, and consequently there are these communication breakdowns that directly impacts the patient.
Terry, you made a very good point. When we work with hospitals with care management, we do say that when they discharge a patient to a nursing home, let's say, they tend to just discharge a patient and you give a report. I highly, highly recommend that if they discharge a patient that morning to a nursing home, that by the end of that afternoon at least, if not, if it was later, at least by the next day, to call back the nursing home and making sure, let's look over all the orders. Is there anything that was missed? Is there anything that you need? That type of stuff. But you have a very good point that when we transfer to a higher level of care, we sometimes the ball does get dropped a lot. So it's a very good, I like the idea, and I'm going to add that also, that when we transfer, that we would also take the time. I'm not sure who the best person would be from the receiving hospital to do this, and they may say, hey, we don't have any time for this. But I think that we should really start that motion, and that within, 8, 14, but no more than 24 hours, that we follow up with the hospital that we referred to. So thank you for that comment.
Well, thank you, Mary. Christine, let's get back to your hospital in terms of the process itself. Tell us a little bit about how the consultation went, when Mary and Carla came in, what did you do afterwards, and talk a little bit more about the process itself, if you will.
Okay. Before Mary and Carla came in, we submitted any documentation that we had so they could see what we actually had in place and what was lacking. And then they came out and spoke to me and to the entire team. And the way we operate our quality improvement committee is every single department head in the hospital has to participate. So that includes maintenance, and that includes the pharmacist and the director of nurses, laboratory x-ray, dietary, every single department head, because we believe that everybody has a role in the overall quality of the care that we provide. But what was very evident to me is that everything that I knew was not everything they knew. That was a part of it kind of shined a light on the fact that there was a lot that was not hardwired. I knew how things worked. I knew how I wanted things done. I knew what the expectations were. I thought that they knew a lot of it. I knew some of what they were doing and how they were doing it, but not all of it. So it really, really gave us a spotlight. It put a spotlight on things we did fairly well, but things that were really lacking. They met with all the staff. They interviewed the providers separately, and it's kind of funny. I mean, and I think you see that at all the rural hospitals. What admin thinks and says is often really different from what the doctors think or say. So there were disconnects in there. A lack of understanding, they asked, have you guys been surveyed? No, we've never been surveyed ever. It's like, seriously, we get surveyed every 3 years. But it was just kind of funny, and some of it is semantics. Well, they didn't realize that, the audits and surveys and, words like that. But it was so important for them to meet with staff with my not being present, and to meet with the providers with my not being present, because that's really when you kind of find out what's going on out there. It is painful when you're asking somebody to come in from the outside and give you a strong, objective perspective, and really you're buying, or in our case, we got this grant, but you're asking for constructive criticism. And you have to be really prepared to take it and to say, okay, I get that, and yeah, we will do that. And in our facility, I mean, we're a 10-bed facility. We have less than 50 employees. We don't run the rural clinic. It's the providers have a private clinic that within our facility that they leave space for. So we are really tiny, and there were certain things that we had to agree that, yes, these goals are incredibly important, and yes, there's a ton. I mean, they have this incredible treasury of resources for us to be able to apply within our hospital for quality improvement. But the way we do it has to be customized to the size of our facility, to the size of our staff. So that was all very interesting. It's like, this is what we're recommending that you do, and some us to say, okay, how can we do this? That makes sense for us, and that will work. They came in the first time and they did the evaluations, and then they came back and presented them to us. But it was incredibly valuable. It was very honest. I think very productive. There were a lot of things that we continued to pull out the action plans and look at them and say, okay, we're having trouble with this, but we can do it a different way. They gave us five different projects to work on, and it's kind of interesting because they're so interrelated that you work on one and you kind of affect the other ones anyway. So it's not a gargantuan task. It's not impossible, but you continue to whittle away at it. And I told the staff, don't be intimidated by this. This is something that we will do every day, even if it's a little piece of it. If you don't mind, I'll get into a little bit of the technicalities. One of the recommendations was for us to hire a discharge planner that would hire a new person. And we advertised for it, and we really wanted a nurse. But we were expanding our telemedicine program and had just expanded our pain intervention program. And so we're short on nurses. And I was not willing to lose a nurse in the clinical care to move over to that, and we were not successful in recruiting another one for this. So what we did is we created a small task force of nurses that would identify some of the issues that needed to be addressed and then work as a team to develop the tools that we could adopt within the hospital that fit the way we do things. So we did new templates for admission and discharge so that from the time a patient comes in, for example, with either community-acquired pneumonia or with heart failure, we have a color-coded chart that is already ready with all the educational materials that patient needs from day one. And so the discharge process and the training process for that patient starts from the minute that they get a room. Materials are in there. There's papers in there for questions that they have. There's an introductory letter from me. And then as things come up, they put more things into that patient's folder so that the education that's being done throughout the stay is documented within the folder. So that was one of the ways to be able to beef up our discharge planning. But it was just a wealth of information, and incredibly helpful. And then we did get a lot of documents after the fact with proposed action plans, and then with our response to how we propose to enact them. So it's very comprehensive. It's very practical. There's nothing in it that I would say, this is ridiculous or this is pie in the sky or, who do they think we are, MD Anderson. There was nothing like that. Everything applied to us in a very practical way.
One of the commentary that, if I may, that Christina, what's admirable of them is they did recognize that there was a lot of work that needed to be done in the utilization review, discharge planning, transition of care, and the ideal, given their present staff, was if they could find somebody else. But even though they did not, so they tried, they did not, then they went back to the drawing board and, okay, how are we going to look at this differently now? So that's a very positive thing that if we all applied, we would be much further along. So, Christina, thank you for doing that.
And
Mary, I wanted to kind of piggyback on that. I think I'm finally unmuted.
Oh, good.
Okay, great.
Well,
okay.
Welcome, Carla.
Is that, and again, to Christina's credit, but it was so obvious that the leadership support pulled the staff involvement, and she has such engaged staff because of that inclusion factor, and I think that needs to be highlighted as well.
And again, in this program, after 14 years we've been working in rural hospitals, we've identified the consulting teams, folks like Mary and Carla, and our consulting teams basically have a track record of translating these recommendations into language that's going to resonate with our rural hospitals. So it is, in our case, finding a combination of good leadership. And Christina is an exceptional leader, partially because she recognizes she can't do everything herself. One of my favorite quotes is from one of the all-time management gurus. His name was Peter Drucker, and he said, "Hospitals are the most complex organizations in the history of mankind." This is an incredibly complex organization. The thought that any one individual or any one hospital might be able to do all the stuff themselves is just simply not practical. So what I've always found is that great leaders, besides inspiring their staff, also carefully select outside expertise that could come and help them. And that it isn't just small hospitals that need help. The larger hospitals do as well, because the complexity of our job is getting greater all the time, and it is finding, kind of wisely choosing who you are going to choose to help, and then applying, kind of practical and very doable sorts of improvement activities. And this applies to certainly to finance. There's generally always room for improvement in finance. And we've never found the perfect rural hospital that couldn't be doing something different in terms of quality improvement or some sort of, basically we all, including our own organization as well. So far, let's talk a little bit, if we will, Christine, about what have been some of the results to date? What has kind of shown up because of the experience that took place in this spring?
I think one of the biggest ones is a higher level of awareness by all the staff about the core measures, about HCAHPS, about the importance. I know that, one of the things that we were struggling with was vaccinations, and when we really drilled down to it, it turned out to be an issue within the EMR, where the nurses were answering yes or no, they got it, but if they answered no, it wasn't picking up the reason. They might have been putting it in there, but it wasn't picking it up to say, no, they already got it. No, they refused it. So it kind of defaulted to, no, we didn't give it. We just didn't give it. So when the nurses realized how important this is to our score, and I've been going to a nurses meeting, and I share with them the hospital compare reports. I share with them the Press Ganey reports that are more recent, that I have a lot more detail in them for internal purposes. But I tell them people are looking at these hospital compares. Probably nobody's looking at them as much as I am, but people are looking at them, and they need to be aware of what people are thinking about us. I do tell them that we do really, really well, but here are the areas that we have room for improvement, and this is what we're going to drill down on. And like Terry mentioned, I'm homegrown. I started here as a volunteer in the community, and I have learned my way through this, but that meant that I had to have great teachers. I rely on other administrators throughout the state. I rely on my providers. I rely on my nurses. I am not a nurse, and so I really, really respect their opinions on clinical care because they're in the trenches. So that idea of pulling from others is so important, but I in turn also have to go back and educate them on the importance of why we're doing the things we're doing. People are being measured to death. The quality measures that are going in, and then some go through NHIN, and some go through NHSN, and some of them are going through CART. Some of them are going directly to the state. Then you have the QHI measures that we impose on ourselves. And after a while, if you're constantly being measured and you don't understand the importance of why you're being measured, it gets to be a drudge. It gets like, I'm so tired of being measured. But if you understand that it's an opportunity to identify areas where you can improve, and then bring in the people who are actually implementing those things, the nurses, they're the ones who are or are not giving the vaccines. How are you recording it, and what's wrong right here? Why is it not picking it up? It could be as simple as correcting a problem with your EMR. It could be as simple as developing a templates for the nurse, and as simple as explaining to them the importance of collecting that data. You're doing a really, really good job, but you're not documenting it. And as we know in healthcare, if it's not documented, it did not happen. So document it and get the credit for the great work that you do. So that was really important to us in this process, is creating that global awareness of quality. What does quality mean, and why is quality important, besides the fact that we just want to be good?
Christina, I also heard you say earlier that you now have implemented colorful patient education to make sure it's going to be meaningful to them. You know, that type of stuff, that are all part of the action plans.
Oh, yeah.
Was there anything else specific, concrete like that you've already succeeded in implementing?
You know, there were so many things that we jumped on immediately that you had given us advice on, talking to our peer hospitals throughout the state to see how they were tackling certain issues and problems, getting some better criteria on denials and why they were denied and what had to be done better. You know, we did expand our telemedicine program, and that was one of the conversations that we had. We also, and this was through the providers also, it wasn't just the hospital side that initiated it, but they have a daily huddle, but of all the providers that are within the hospital. Come together and they discuss every single patient that's in whether they're OBS or full admission. And now the pharmacist is a part of every single huddle to be able to give his input in terms of the medications that they're getting. And now we've been able to hire somebody as a pharm tech to give him free time, so when the patients are discharged, he gets to go talk to the patients about their medications.
Yay!
Get an understanding of whether or not they know what to take and how to take, and then beyond that, get an understanding of whether or not they can afford those meds. And what we can do about it.
Congratulations, Christina. I'm so glad to hear that.
Yeah, there's a lot that came out of this, and it seems piecemeal, but overall, I mean, it's pulling things together.
Oh.
And in essence, you know, there is somewhat of a formula of things that, you know, in 2015, that rural hospitals should be looking at from both a clinical standpoint, a business standpoint, an operational standpoint as well. But it's got to be individualized, and I think I heard Christina saying that before. It's got to be the right thing and done in the right manner in a 10-bed facility. And the concepts are very similar from one part of the country to the other, or from one large rural hospital to a smaller one in that regard. The sort of things that we're talking about here are things that could be done in virtually any rural hospital, and is something that we hope, you know, through the kind of educational programs we're doing, through the actual work on site, that we can bring some of these ideas, resources, tools, etc., out to more hospitals. What would be terrific is if we had tons of dollars available to do these consultations on site for, you know, hundreds of different hospitals. But given that that's not the fact, there's always limited resources for everybody. What we're trying to do now is to take these ideas, tools, resources, etc., and find a way to bring them out to a lot of other hospitals that we may not even have ever talked to before. And these kind of initiatives, I think, are going to be extremely important. And again, we're field testing them in rural hospitals and then making them available. This is not something you're going to find in the journals of Harvard Business School, but in our experience has been that rural hospitals learn best from each other.
I agree. You know, we created a New Mexico hospital, rural hospital network for that reason. The independent hospitals, we don't have this corporate structure and those resources, so we lean on each other. We adopt best practices. We we established or recognized a champion in each field. So there's an IT champion at one hospital, and he leads the other hospitals in IT. Or you can call them and say, hey, call your champion if you have a question. This morning I had an issue where my IT guy came in and said, you know, I want to review this contract. I said, I'm not buying into it, but I don't know enough to say yes or no. Contact your champion, get input, and let's go from there. So that idea of working with other hospitals is so, so important. But in terms of the value from this program, from the Small Rural Hospital Transition Program, I just cannot express how many resources they provided to us, and varied resources. So they provided forms and formats and structures and instructions for even discharge process. They provided similar for care transition, which is a part of discharge process, or discharge is a part of transition. They go hand in hand. They provided information on utilization review, how best to do it, when and by whom. So, I mean, I can't even count how many emails and how many attachments I got from Mary and from Bethany and from Carla. I mean, and they're wonderful because they're there. And anytime we have a question, it's like, go back into that treasure trunk and see what we can use and what we can pull out and customize for ourselves. So it's just been wonderful to not have to reinvent or invent any of these things. They're there already. We can just adopt them.
Well, I appreciate hearing that. I also just want to acknowledge Bethany, who is, has access to tons of these materials and provides support to our consultants and our hospitals as well. So I'm really pleased to hear you say that, Christina, because we care as passionately, I know, as you do about quality in our rural hospitals, et cetera. And again, for me, I care about it personally recently because of my mother's experience, but everybody has a mother or had one at some particular point in our children, et cetera. I don't think there's any more important conversation, financial or otherwise, than the one we're having right now. Mary, I want to ask you, or invite Carla to jump in here too. Let's talk a little bit about preparation for accountable care organization and why this is important in that regard.
Well, kind of what I was, saying earlier, because the population. I'm sorry. Did you say population health management, right? What did you say?
I did, and the relationship, which is a big part of ACOs,
right.
And so
right. So the hospitals who are going to be, whether it's invited in ACOs or invited in being a provider for bundle payment, or invited in an affiliation, anything like this, would have to be able to show how they have managed the triple aim, which is their quality care, high patient satisfaction, engagement, and cost management. How to do it best at the lower cost is really what they're looking at. So all of this prepares us for the management, because if we keep our patients, if they come in and we do not do any harm to them, first do no harm, and we help them to truly transition into a sustainable program, we are automatically decreasing the cost, getting our patients more involved, and having higher quality, programs. So when we are going to be paid, most everybody is going to be paid a certain amount of dollars per members. Medicare is looking to have most of their population, 80 some odd percent of their Medicare beneficiaries, to be paid that way. Somebody else is going to be. So if I'm the ACO or whatever you want to call me, if I get paid from Medicare, I'm going to be looking for people to put on my team that are going to have that triple aim in mind. The least amount of cost for the best outcome, sustainable outcome. That's how we're going to do, that's where the value is going to be going forward. So to me, that's a great step there. And let's not forget, if we do good transition of care, well, hopefully we will have less ED visits. And when they do need a visit, that it's going to be at the appropriate level, which should be in a clinic and not in an emergency room. So it's kind of like what Christina said, everything's a domino effect. Very hard these days to write one action plan that's not going to affect three other, projects. So I hope that that's what you wanted me to chat about.
Absolutely. And in fact, this is the question that I'm asked most now as I, travel around the country talking to hospital leaders. And that is, what should we do to position ourselves to be successful in this new world of ACOs and new Medicaid models? We know that the insurance companies are rapidly moving into this direction as well. So, Christina, I want to ask you about that. And again, what we see in some states, the movement is very rapid. I mean, ask the Oregon hospital leaders who have to do this because they're a part of them. All their Medicaid is now in an ACO-like model. What is happening in New Mexico, and what might you be doing then to position your hospital to be successful in the future, either under whatever?
Yeah, a couple of things come into play. The state put in a new waiver for Medicaid. It's called Centennial Care, and it's got some value-based component to it. So, quality is very important. It used to be our sole community provider program, which was kind of based on the upper payment limit between Medicaid and Medicare. And now it's the safety net care pool for rural hospitals. That has a quality component to it, kind of like a DSRIP. In terms of ACOs, right now, a good number of the rural hospitals joined the National Rural ACO, kind of on a trial to see how that goes. And I was one of those that kind of sat on the shore and do I jump in, do I not jump in, do I jump in? And I decided not to at the very end. And I thought, I'm fine not being a part of it. This was not one that we would get any actual improvement or monies back on. That wasn't a possibility. But it was going to be something else that I had to continue to report more. I think because of this program that we participated in with Mary, and because of the financial reviews that we've had and the improvements that we've had on that side, that we're doing kind of what this National Rural ACO was going to help them prepare to do, which is really, really improve care, reduce costs, and also improve the health in our population. So I think we're headed towards that anyways. I think, when we look at it in the long run, how they're going to form the ACOs, will they come to all the rural areas? Will the rural areas be that 15% that isn't a part of the ACOs? I just don't know how that's going to go. But I can assure you that our goal is that when the time comes, we will be very ready and we will be very attractive to anyone that comes looking. Yeah. By having high quality scores, by having low costs, by having low readmissions, just being a really well-run ship. And in the process, if that doesn't happen, if the ACOs don't come out here, if the bundle care, because there's not a whole lot of stuff we can bundle with out here in the middle of nowhere, but the doctors in Albuquerque may say, we trust you guys to provide the follow-up care for our patients. There is a possibility for that. We will be in a position, either way, we will have become much better at what we do, even if they don't choose us to be a part of their group. So there is no downside to being better.
Yeah. And what I'm hearing you say, and I think is very, very well said, is that whether or not you become an ACO, you jump into that at this time, basically the goal is to build value as a rural hospital. And that if you build value as a rural hospital, you're going to be okay. I mean, that in essence you will have ready partners reaching out to partner with you. I can almost guarantee that as such. It's very obvious. I spend a good bit of time talking to folks in the larger tertiary centers, the Mayo Clinic, et cetera, And the advice I get from Mayo is tell the rural hospitals we're looking for high-value, high-quality partners. We don't need to own you. We don't need the old sort of way to do business. We're really intent on just finding a group of rural hospitals that are going to provide that high value.
And you know, and it's happened. We've had some of the big hospitals in Albuquerque come out and kind of court us, and it's kind of neat because I remember in the past, you know, we went through all these turnovers and bankruptcies, you know, 93 and 99, and we were always the ones that were asking and begging, pleading for help. And it's kind of neat for them to come and ask us to partner with them, not based on sympathy and charity, but on the fact that we're really good at what we do. That's really exciting.
Terrific. Yeah, that is exciting. And again, in the new system, rural hospitals and rural clinics are going to have enormous value. The good ones are. And I think, Mary, you want to maybe, or Carla, either one, kind of say a few words about that from...
Well, yeah, the one thing is that, and Terry, you've done a lot of presentation about this, so have we and many others, about the lower cost of care in rural, number one. Number two is that on the average, age cap is higher in rural. Number three is because they are small, we can definitely show our value with the core measures and everything else. It is easier in a way to be able to manage. But what hospitals, I'm thinking, is that the bigger hospitals, save your beds for those high intensity, high acuity patients, and those patients who can be taken care of in rural. Why not affiliate somehow or other with the rural hospitals to be able to manage those patients? And as we all know, the people who are going to be owning this is kind of like the physicians, because they're going to be, you know, they're the ones that the lives are going to be attributed to. So if we have a good relationship with our physicians and we offer a very good service for those lives, then why send them in a big center when it's something that we can do at our own hospital? So I think that there is room, unbelievable amount of room for great low-cost quality care in our rural hospitals, even in the new system.
And Mary, I want to piggyback on that too. I think that what Christina's group is doing as part of this project is extremely important in identifying the underlying issues that are going to affect care coordination.
Right.
And that's just hugely important as we move forward.
Yeah, you guys are just so right on point with this in essence that, we're already seeing tertiary care centers that are transferring post-acute care patients directly out to critical access hospitals, taking them from the big city. They live in the big city, and I can give you examples of a number of hospitals that are receiving patients directly from these tertiary care centers because they recognize that they can provide that care more effectively as such. And so we've unfortunately ran out of time. What a stimulating conversation. I've really enjoyed it. Hopefully our listeners have as well. This is the performance management group calls. We do these on a regular basis. We would encourage you to dial into our future calls. We also have check on ruralcenter.org and our Small Rural Hospital Transition Program, because we have some really great webinars. If you haven't, just go back through, look at the last 12 webinars that we've been doing. They've been uniformly extraordinary. So I want to thank our speakers. I want to thank those of you that are on this call, and have a wonderful weekend. And again, thank you very much. Goodbye.
Thank you. Bye-bye.
Thank you. Bye.
Thank you.
The organizer